Thank you, Dr. Soumelis and Dr. Savidou, for the invitation. I'm happy to speak about ultrasound of the elbow in the context of trauma. Elbow trauma. And as the audience is a clinical audience, I'll just try to highlight the indications of ultrasound compared to MRI. We spoke about CT, so we are now going to speak about tendons and ligaments and compare the two methods. So as a rule of thumb, ultrasound is used for high-resolution imaging, so superficial structures. While if we want to image deep-lying structures and osteochondral lesions, we're going to use MR. A very big advantage of ultrasound is the dynamic tests. You already use them in your clinical tests, but in imaging it's very helpful, especially in cases of tears. So if you have a tear where the two sides of the two parts of the tendon are close to each other, sometimes it's very difficult to diagnose even on MR. So when we do a dynamic test, the two sides of the tendon move one apart from the other, so we are very confident about our diagnosis. Color Doppler is very useful for assessing tendonitis, and we do not have to inject contrast agents as we do in the case of MRI. A very big advantage is the contralateral comparison. We have the other arm we can examine at the same time. And in MSK imaging, we don't really have any normal values. So it's very important to check in each patient what is the caliber of his other normal hand, and then speak about inflammation or bigger dimensions. And the last and most important part in my clinical practice is the interactive nature of ultrasound. You have the patient with you. The patient can guide you according to his symptoms, even in another anatomical area, and you are much more confident about the diagnosis. So this was just to sum up the indications of ultrasound. So we resumed the indications of ultrasound in 2018 in the European Society of Skeletal Radiology. I was part of this group, and what we try to do is to actually classify where ultrasound is indicated. So with 0 is when ultrasound is not really indicated, and with 3 is when ultrasound is the gold standard. For example, here you can see in cases of epicondylitis or triceps tendon injuries, ultrasound is the method of choice, while for collateral ligaments and the medial and the biceps tendon, MRI is also a very strong diagnostic technique, and in some cases is superior, especially in collateral ligaments, as we will discuss in the next slides. As discussed before, if we are looking for an osteochondral injury or a fracture, we won't be using ultrasound. And we will be using ultrasound as a gold standard in cases of nerve imaging, but this is beyond the scopes of this talk. So focusing on elbow trauma, the pathology we'll be looking for with ultrasound is joint effusion, tendon abnormalities, and ligament abnormalities. Regarding the joint effusion, we'll be looking for the infusion either on the posterior olecranon recess or anteriorly in the coronoid and radial recesses. It is helpful to press with the transducer, and we can see the fluid being displaced or the recess being collapsed. And we also get negative flow on color Doppler, and this is a good differential from synovitis. Here you can see on the, my pointer is there, okay. So you can see here the fluid, how it appears on ultrasound, and how on the same patient we can see the fluid on the in the olecranon recess on T1 weighted sequences. Intraarticular bodies can be detected with ultrasound, but not always. If they are in the ultrasound spectrum where we can scan, we can see calcified and ossified bodies. It is helpful when they are surrounded by fluid, and it is also helpful when we do dynamic movements and we see them moving, and this is how we differentiate from osteophytes. This is a case of an intraarticular body, and which was also apparent on the X-ray. Tendon abnormalities is going to be the main focus of this talk, and especially the distal biceps tendon. So we can, of course, diagnose tendinosis. We can see the tendon hypoechoic swollen. We can find positive Doppler signal. But we can also very nicely differentiate partial thickness from full thickness tears. In the distal biceps tendon, just a small summary of the ultrasound technique. We use 4 approaches, and we also use dynamic scanning, supination and pronation, and this is very important for our diagnosis. Anatomy is key, as always, so when we scan, it's important to remember that the long head is lateral and the short head is medial. So knowing the anatomy and the course of the tendons is very important. I'm going to go through an ultrasound scan, so just wanted to revise the anatomy before I do that. So the long head passes deep to the short head and inserts more proximally. So inserts first, and then the short head inserts more distally. They both insert along the ulnar margin of the distal tuberosity, and this is the anatomic situation that causes some difficulty when scanning, so we have to be very experienced when we scan, trying to send our beam perpendicular to this tendon. This is why we use all these approaches and all these dynamic maneuvers. It's not a very easy scan. So I'll just show you how we perform the scan on transverse view. This is the tendon, the distal biceps tendon. Here you see the brachial artery. We have the brachialis muscle below them, and then as I scan and I go down, you can see the tendon as it divides in two heads. We see the long head going deep down and going down to the radial tuberosity and inserting first, and then the medial head inserting more distally. All the way down, you can see the median nerve and the brachial artery. So I'll just play this video once again. Maybe you can follow easier now. You can see the 2 heads as they separate. The short head, the long head going deep and curving around, trying to insert into the radial tuberosity first, and then more distally the short head. So another important finding we can detect with ultrasound, another important structure is the lacertus fibrosus, which is the distal bicipital aponeurosis and originates from both the long and the short heads. It lies superficial to the brachial artery and the median nerve, and it runs medially and distally to insert on the peripheral aponeurosis of the flexor muscle. So it's important to try and localize the lacertus fibrosus and report to the clinician if this is also torn or not. So I'm going to play this video now, and before I do, I'll just remind the anatomy again. So here we have the tendon, we have the artery, and we have the nerve. Here are the flexor muscles, and on top you see this small white structure, which is the lacertus fibrosus. And when I ask the patient to contract his arm, then you can see that the lacertus is intact. So this is a good trick to check if the lacertus is intact in the context of a tendon tear. Now this is how we see the appearance of ultrasound. I hope you're interested in that and want to get a little bit more familiar with ultrasound images. This is why I'm explaining in more details. So here we see the muscle, and here we have the tendon inserting on the radial tuberosity. We have the brachialis muscle, deep to that, the pronator teres, and the brachial artery on top. So this is the image we should get when we scan for the biceps tendon, and this is the part of the tendon. We also always scan in 2 perpendicular planes when we perform ultrasound. We should be able to visualize the tendon in transverse scan, which is here, the brachial artery and the nerve, and this is the famous BAM section we have in ultrasound when we are scanning for the distal biceps tendon. So here is how a full thickness tear looks like. We have the radial tuberosity. We see the tendon retracted. We can measure the retraction and mention to the orthopedic surgeon so he knows. And then on the transverse scan, we see again this anatomic area being empty without any tendon fibers. The main importance of ultrasound, according to the literature, we have a very recent publication where 150 elbows were scanned. And we found that there was a superiority in ultrasound for detecting high-grade partial tears. So it is more useful than MRI when we are suspecting a high-grade partial tear. And you can see here the anterior part inserting, which is the medial head, while the posterior part is missing, the long head is missing, so we can report a long head tear. Moving to ligament abnormalities, and I don't want to take more of your time, I'll just go quickly through that. We can evaluate partial tears, complete tears, and of course dynamic stress tests are very useful in this situation. Here is how the ulnar collateral ligament looks on ultrasound. We have the medial epicondyle and the coronoid process, and this ligament bridging the two. Sorry. And here on MR, you see a full thickness tear of this ligament. On ultrasound, this is a partial tear. This is an older image. And then we have, again, on MR, the partial thickness tear of this ulnar collateral ligament on the same patient. On the radial collateral ligament, remember, it lies always deep to the common extensor tendon, as it was mentioned before. So it's easy to visualize, and when we perform a dynamic maneuver, we can see how heterogeneous the area is and how evident the tear is on coronal T1 post-gadolinium injection. So that was about it. Thank you for your attention. I hope this was useful.